Greetings and salutations once again, ladies and gentlemen, and welcome to the second episode of Neurology ABCs. Today, our topic of discussion is going to be amyotrophic lateral sclerosis, also known as ALS, also known as Lou Gehrig's disease. Named after a famous American baseball player, amyotrophic lateral sclerosis is a neurodegenerative disease that affects the motor neurons, which are structures that originate from the cortex of the brain and ascend towards the spinal cord. They can be divided into two types of neurons, upper motor neurons and lower motor neurons. The collective involvement of both of them corresponds to the skeletal muscular symptoms perceived in this disease. If you remember, in our last video we talked kind of about Alzheimer's, and one of the things in common between these two diseases is the accumulation of certain cellular deposits, whether it's in the cortex of the brain, such as in the case of Alzheimer's, or in the case of ALS, where damage usually involves the upper and lower motor neurons. Now, ALS, being one of few other motor neuron diseases, has a gradual and insidious onset, usually progressing over 3 to 4 years, but also sometimes having a delayed progression, such as in forms of ALS with a familial history, where progression can actually be in the span of more than 20 years. It's also important to mention that familial forms of ALS usually have an earlier age of onset as compared to sporadic forms of the disease, where the age of onset is usually between 40 and 70 years old. A quick clarification: what I mean by the span of progression is how long it will take for the disease to eventually lead to death, which kind of means that the sporadic form of ALS usually kills a lot quicker. There's also this thing called Guamanian ALS, and it's pretty much an acquired form of the disease. It's also a complex that shares some syndromes with Parkinsonism. It's mostly the result of neurodegeneration due to a chemical called beta-methylaminoalanine, and apparently this disease is extremely rare and you probably will never come across it in your entire clinical career, but for the sake of completeness I thought I might as well mention it. In terms of clinical presentation, the most substantial feature of amyotrophic lateral sclerosis is the involvement of either the upper or the lower motor neurons, or both of them simultaneously. This can be perceived as general atrophy of the muscles of the body. However, one of the more specific clinical features of ALS is the non-involvement of the ocular muscles or the cortex of the brain, thus the higher cognitive functions and ocular movement are often spared. This compared to another neurodegenerative demyelinating disease such as multiple sclerosis, however, in which the involvement of eye movement is quite a substantial clinical finding. Another thing preferable to compare between amyotrophic lateral sclerosis and multiple sclerosis is the progression rate. Progression rate is usually a lot more gradual in multiple sclerosis compared to ALS. This will prove later on quite substantial when comparing the prognosis of these two diseases. Also, something specific about ALS is that it spares the sensory functions as well. So you probably won't find lack of sensation in a part of your body in ALS unless there is another underlying health issue within. Now, it's actually quite crucial to differentiate the impairment of the upper motor neurons or the lower motor neurons to properly understand symptoms of motor neuron disease. Now, if you remember from neurological anatomy how the lower motor neurons are responsible for the resting muscular tone as well as the tendon reflexes you can examine in different joints. Thus, the impairment of lower motor neurons will present as weak reflexes as well as lowered muscle tone. Also, remember that fasciculations are specific to lower motor neuron injury, whereas the Babinski sign is specific to the upper motor neuron injury. Now, aside from generalized muscle weakness and muscle wasting, there are also some other more local presentations of ALS, specifically in the case where ALS localizes in the midbrain. In this case, you can find that the ability to swallow and chew are affected. It's also important to remember that the progression of midbrain involvement, especially towards the breathing centers of the midbrain, is the most common cause of death in ALS. The quick terminology here: the symptoms I just mentioned all fall under the term of progressive bulbar palsy. For the finale, we'll talk a little bit about diagnosis and treatment of ALS, and then we'll wrap this episode up. So in terms of the diagnosis of ALS, it's a little tricky. It's mostly through exclusion, so you just have a huge list of a bunch of diseases and you just have to keep excluding each and every one of them. You might do MRI scans, you might do electrical studies of nerves, and eventually you keep disqualifying these diseases until you're left with only ALS. And you also need the agreement of another neurologist most of the times for the disease to be officially diagnosed. So here's a split picture of the list I just gave you for those of you lunatics out there who are crazy enough to attempt to memorize it. So the majority of the diseases listed here are extremely rare, And if you actually want to get something out of this list, I might as well recommend that you at least check the ones I'm going to mark with arrows, especially the blue ones. And aside from that, I think that we've already covered ALS in a little too much detail. So, moving on. In terms of treatment of ALS, unfortunately, the only thing we can do is palliative therapy. There's this drug that allegedly can extend the life expectancy by like a couple of months. The drug's name is riluzole. Not sure if I'm pronouncing it correctly. The treatment also involves antimuscarinics such as atropine and scopolamine to treat excess saliva production. There's also baclofen, which is a gamma-aminobutyric acid agonist. It's used to treat excessive muscle tone and spasticity. Sorry, but I forgot to mention in clinical presentation of ALS something called the pseudobulbar effect, which is just a number of sudden outbursts of crying or laughter that can be seen in many other neurodegenerative diseases such as ALS, Alzheimer's, multiple sclerosis, other forms of dementia, etc. And finally, for the conclusion of this video, I would like to give a special thanks to anyone who has actually made it this far, and I guess it's time for the recap. So, like mentioned previously, sporadic ALS is the most common form of ALS, and it usually happens between the ages of 40 and 70 years old. Familial ALS happens a lot earlier and is usually more gradual in progression. Sensation, cognition, and ocular movement are spared in ALS. Bulbar manifestations cause death, especially when the breathing center are involved, and it's the most common cause of death in ALS. Riluzole is a drug that can increase life expectancy, but it does not stop the progression of the disease. This is the ending of this video. I hope it was informative, simple, and enjoyable enough for you guys. And I guess until we meet again in the next video.